Today I am presenting the study conducted by Ashish Khanna and colleague. It was published in Journal of Clinical Anesthesia in 2017. You can find this article in PubMed search engine. The study compared the effect of ropivacaine with or without fentanyl versus bupivacaine with fentanyl for post-operative analgesia in bilateral total knee replacement. This study covers the concepts discussed in Unit 1 in post-surgical pain models, Unit 3 in survey tools for assessment and measurement of pain in human subjects, and Unit 2 utility of preclinical and clinical models in drug discovery. The hypothesis of this study was that ropivacaine with or without fentanyl provides better pain management with less motor blockade in comparison to bupivacaine with fentanyl in postoperative TKR patients receiving patient-controlled epidural analgesia. The objective of this study was to compare the analgesic efficacy and side effects of postoperative patient-controlled epidural analgesia with plain ropivacaine 0.1% with or without fentanyl versus plain bupivacaine 0.06 to 5% with fentanyl 2.5 microgram per ml in patients undergoing bilateral TKR. Pain assessment and early mobilization, including hospital stay, was the secondary outcome they wanted to observe. So how is the pain perceived? Just take an example. Suppose if you get a cut or like we get a bee sting, then happens the process of the transduction. This is the process by which afferent nerve endings take part in translating noxious stimuli into nociceptive impulses. There are three types of primary afferents: A beta, A delta, and C fibers. A delta and C fibers are responsible for nociception. The silent fibers take part in transduction but only involved under inflammatory event. And then happens the transmission. The impulse is transmitted to the dorsal horn of spinal cord, and then following sensory tracts, it's sent to the brain. These primary afferent neurons are sensitive to chemical and electrical signals. Their axons terminate in the dorsal horn of spinal cord where they relate to many spinal neurons. And then happens the modulation. Modulation of the pain occur peripherally at the nociceptor, in spinal cord, or in supraspinal structures. This modulation can either inhibit or facilitate pain. And then happens the perception. Perception is the conscious awareness of the pain experience. When we experience the pain, it's a series of events which starts with transduction, transmission, modulation, and then other factors such as individual personality, psychology, and emotional state play a role in this event. So why choose patient-controlled regional analgesia? The pain is a complex sensation which is difficult to define and equally difficult to measure in an accurate, objective manner. Postoperative pain differs from other types of pain in that it is transitory, with progressive improvement over a relative short time course. The studies have suggested that most adults expect to have significant pain post-operatively, and that is their primary concern. And that is very true. When the patient comes to the hospital for pre-anesthetic checkup, their first question is what kind of a pain I will have and how you're going to manage that pain. So these concerns may be justified as traditional management of pain comprises the prescription of a standard dose of an opioid to be given on demand by a nurse. And it happens, when the patient threshold has been already exceeded when they receive the pain. This leads to poor control of post-operative pain due to the reason, like, the responsibility for management of pain is delegated to the staff and who are on the side of the caution in the administration of opioids, and which is right. They tend to give a small dose of a drug because of unwarranted fear of ventilated depression or addiction. Because the administration of drug is left entirely on the discretion of nursing staff, the degree of empathy between nursing staff and the patient affects analgesic administration. And because measurement of pain is difficult, it is difficult to adjust the dose of a drug to match the extent of the pain. So what happens, in total knee replacement patients, it's a major surgery. Post-op pain reports are higher in these patients owing to the fact as surgery involves bone drilling, surface periosteal scraping, and tissue damage to the nerve endings at the surgical site leads to severe post-arthroplasty pain. So what happens, why PCA? The patient control analgesic, it is very cost effective because superior analgesia with higher satisfaction And it has been reported that the administration of local anesthetic opioids or combination neuroaxillary is an excellent technique for managing postoperative pain in the patients who are undergoing abdominal orthopedic surgery or pelvic surgery. And patients have better preservation of pulmonary function, early mobilization, and then, of course, they will have decreased risk of DVT, like deep vein thrombosis. And studies have shown that the patient control analgesia, it is very cost effective technique that produces superior analgesia with very high patient satisfaction, and the total consumption of the drug is very low in comparison to the IM opioids or intramuscular opioids. Methods and materials. This study was prospective, randomized, double-blind, single-centered. Inclusion criteria were bilateral TKR under CSE. The patients were between 40 to 60 years of age and female. Exclusion criteria included the patient's refusal, revision TKR, anticipated technical difficulties such as kyphosis or any other anatomical deformity in the patient, body weight less than 50 kilogram, and any history of local anesthetic allergy, local sepsis, inability to use PCA pumps, and substance abuse and dependence. 90 post-TKR patients with ASA status 1 and 2 randomly allocated to receive post-operative analgesia as per one of the three PCA plan. Group 1 was with plain ropivacaine 0.1%, Group 2 plain ropivacaine 0.1% with fentanyl 2.5 microgram per ml, and Group 3 was plain bupivacaine 0.0625% with fentanyl 2.5 microgram per ml. The subjects were educated and is instructed how to respond to VAS score and how to use PCA pumps in advance. Pre-medication was given the night before the surgery, alprazolam 0.25 milligram and ranitidine hydrochloride 150 milligram. In the operating room, routine regional anesthesia protocol was followed, and epidural, combined spinal and epidural was given using 0.5% bupivacaine, hyperbaric, and intrathecally, and then epidural supplement using plain 4 ml 0.5% bupivacaine. The block level ascertained by using pinprick method, and was once the surgery was already completed and the patient was then shifted to the post anesthesia care unit, was score was assessed again. So how they started the PCEA. If the PCEA was score was more than or equal to 3, they initiated the PCEA, and the basal rate was 4 ml per hour, and the demand dose was, if the patient was still demanding the drug, it was 6 ml per hour bolus. Signs of the respiratory depression, bradycardia, and hypotension monitored in all the patients, and rescue antiemetic like ondansetron 4 milligram was given to these patients. The patient satisfaction was overall they assessed using the 4 points patient satisfaction scale. Statistical analysis, continuous variables were presented as mean, standard, plus minus standard deviation or median, minimum to max. The Shapiro-Wilk test was used to scrutinize the data for the normal distribution. A normally distributed continuous variable were compared using analysis of variance. Categorical variables were analyzed using the chi-square test for all statistical tests where appropriate p-value less than 0.05 was taken to indicate a significant difference. So in the results, median pain score at rest and motion was significantly low in ropivacaine with fentanyl and bupivacaine with fentanyl in comparison to ropivacaine alone group. When we are looking at the patients with ropivacaine alone, they needed frequent PCEA administration rather than the two other groups like ropivacaine with fentanyl or bupivacaine with fentanyl. So we can see that when we added opioids to these drugs, it did play a role for the prolonged analgesia in all these post-operative patients. Motor block was greater in bupivacaine fentanyl group than the other two groups. Incidence of vomiting was found in all three groups, but when we are looking at the ropivacaine group, they had a less incidence of nausea. So by looking at the tables, you can see that pain score after 4 hours of the surgery at rest and at the motion was comparable in both the groups. However, after 4 hours, you can see the median pain score was significantly lower in ropivacaine with fentanyl and bupivacaine with fentanyl group at rest and at motion as well. When we look at the table, patient's demand and drug delivery, we can see that after 12 hours postoperatively, the patients in the ropivacaine alone group required greater frequency of rescue analgesia than the other two participants groups, such as ropivacaine with fentanyl and bupivacaine with fentanyl. So, and they had an increased number of drug delivery. So what we can see that addition of the fentanyl to ropivacaine returned improved quality of analgesia, and it was comparatively found to be superior to plain ropivacaine. So in the conclusions, PCA administration of ropivacaine fentanyl combination leads to adequate postoperative analgesia. It had a quantitative reduction of local anesthetic drug usage and heightened satisfaction. The addition of fentanyl to local anesthetic solutions, that is ropivacaine and bupivacaine, except for minor burden like postoperative nausea and vomiting and itching, ensured better postoperative analgesia and patient satisfaction. In comparison to ropivacaine alone and ropivacaine fentanyl combinations, bupivacaine plus fentanyl was associated with greater intensity of motor blockade, and overall in terms of postoperative pain relief and motor blockade, ropivacaine fentanyl combination was found to be superior. That is, it like it had a good analgesia and lesser motor blockade to bupivacaine fentanyl, good analgesia but with significant motor blockade, and ropivacaine alone, which did not provide the adequate level of the analgesia. This study also provided the supporting studies which did the same like similar studies on the patients like Fernando's and colleagues. They conducted the studies on the parturients, assessed the analgesic efficacy and degree of blockade with epidural infusion of bupivacaine with fentanyl or ropivacaine with fentanyl. What they found was that analgesia was equally effective in both groups. However, the small incidence of motor blockade was observed in bupivacaine patients. And Coempe and the colleagues compared the ropivacaine 0.1% with 1 microgram of ml sufentanil versus ropivacaine in 30 ASA status 1 to 3 patients undergoing total hip replacement. They observed that patients who received ropivacaine sufentanil consumed less intravenous opioid over 48 hours post-op period than the ropivacaine alone patients, and motor blockade was negligible in these patients. So in the strength and limitation, the strengths of the study are like it is prospective randomized double-blind study, and it provided the strong evidence that ropivacaine with fentanyl and bupivacaine with fentanyl provide better post-op pain relief. However, the only limitation in this study is it has been conducted only on the TKR surgery patients, and they used a small sample size. And that's it. And there are the reference which thank you. Hope you enjoyed. Any comments are really appreciable. Thank you.